Hey everyone, this is Dr. Murphy bringing you another episode of Banff and Beyond. We will continue our discussions on infections that occur in the transplant setting with our next case. Our patient today is a 73-year-old male who presents with acute kidney injury, increased urinary frequency, proteinuria, and hematuria, status post-transplant approximately 3.5 years ago. His past medical history includes diabetes, hypertension, coronary artery disease, and prior prostate cancer. The patient was preemptively started on Augmentin for a possible UTI, which was subsequently discontinued once cultures were found to be negative, and thus a biopsy was pursued. As we begin to look at the biopsy, at low power, you can appreciate that there is minimal blue throughout the majority of the interstitium. However, if we examine this second low power image, we can see that there is a focal patch of dense blue interstitial inflammation. So while most of the biopsy appears spared and in good shape, there is one area comprising approximately 10% of the biopsy that we need to examine more closely. Moving up to high power, on this H&E stain section, we can see that there is a brisk interstitial infiltrate composed of lymphocytes, plasma cells, histiocytes, and interestingly, more neutrophils than we would typically expect to find in a classic example of acute rejection. As we continue to look around, in this next image, we see brisk inflammation, but in addition, we can appreciate white blood cell casts and cellular apoptotic debris, along with enlarged, reactive-appearing tubular epithelial nuclei. Additionally, there is also lymphocytic and occasional neutrophilic tubulitis. Here, we can appreciate a tubule with severe tubular necrosis and subsequent epithelial sloughing and associated apoptotic debris. If we turn our attention for a quick second to a high-power view of a representative glomerulus, we can see that we have overall normal-appearing glomeruli with no mesangial expansion or glomerulitis. And if we look at a representative artery, we can see they look very good with no intimal fibrosis or endotheliitis. Thus, with this constellation of findings, a possible viral infection is in the differential. However, our SV40 stain for polyomavirus was negative, as was our CMV stain. The answer finally revealed itself with our adenovirus stain, as you can see from this low-power view that the stain is focally positive in the focal areas of interstitial inflammation. And at high power, you can see that the reactive epithelial nuclei that we saw previously are the cells with positive staining. On follow-up, the patient was indeed found to have a positive adenovirus titer and was subsequently treated. Of final note, a few other helpful histologic findings that may be seen in an adenovirus infection, although not seen here, includes interstitial hemorrhage as well as granuloma formation around infected tubules. As always, thanks for everyone's time and look forward to seeing you again in the next case.